So welcome to the University of Rhode Island. We are very excited to sponsor you today. My name is Nina Jacobson. I'm a faculty member in College of Pharmacy. I do have a presentation. But I just wanted to let you know that we do have some coffee, tea, pastries. Please feel free to help yourself. We also have some gift bags, so please everyone take a gift bag, and we are excited to host you today. So thank you for coming. Thank you.
Everyone on the committee and in the room, we're just waiting for 2 more bodies to arrive so that we can have quorum and begin the meeting. So please do help yourselves refreshment and gift bag. And we let folks know on Zoom that we're just waiting for final arrivals, and we will start soon. Yes.
Marty. Sorry, I think someone. Brandon got it. Dennis, how we doing? Great to see you.
Pretty good. That property situation.
Yeah.
Pretty good.
Like a scavenger.
Yes,
Well done.
So
Yes.
Hey, good afternoon, everybody, and thank you for your patience as we allow folks to get settled in the negotiation and make their way to the building. I hope everyone had an enjoyable drive down on a beautiful day, and that you wore comfy shoes to get your steps in and you want to facility. But we are glad to have you again and appreciate Nina and College of URI hosting us down here this afternoon. The day is flying by. If you didn't hear the announcement, there are refreshments at the end of the room, and there's a gift bag for committee members to take before you leave as well. And apologies, I'm Carrie for disbelief, and I am the chair of the Opioid Settlement Advisory Committee. Our agenda today, we are looking forward to a number of great presentations. First, we're going to have Marty give a quick update on the status of our FY 23, 24, and plans for 25 funding allocation, as we have done as we have made a matter of practice in our meetings. And then appreciating the feedback that we've received, we have 2 opportunities for public comment this afternoon. So the first will be after Marty's presentation, and then by our subject matter expert presentations this afternoon. So we have Dr. Serena Bradford presenting about pharmacy intervention, and on the Zoom, we're going to have Dr. Schwechtenbaum presenting on oral health. We will follow that with a presentation about the TAPA settlement and the first responder program specifically here at URI. With some updates and a little bit of coming attractions for our next couple of meetings. We'll have our second segment of public comment, and then we will adjourn before, for those of us who are able to stay, heading to the, press conference. I also want to make some acknowledgement of, new committee members before we do our round of introductions. Representative Cole has been appointed to the committee, and so we welcome Representative Cole, who is, well, this will not be his first meeting, but we will be here for, hopefully may be able to make this meeting, but we'll be representing, the House of Representatives. We also want to acknowledge and thank Director Charest, who has, appointed Dr. Servo in his place, because, as you all probably are following in the news, Director Charest is up for confirmation by the full Senate, to be the Secretary of Health and Human Services. And so Dr. Servo is acting as the Director of BHTDH and has been appointed to the BHTDH to the seat on this committee. So we welcome Dr. Servo, who unfortunately is unable to join this afternoon.
He just turned his camera on.
Oh, great. Connected by Zoom. Great. Thank you. Welcome, Dr. Servo. Nice to meet you.
Thank you.
Absolutely. And also want to acknowledge Rachel Newman Green, who is the acting director of the Healthy Communities Office, who is has been appointed by Mayor Smiley. Rachel was unable to attend today, unfortunately, but we also will welcome Rachel hopefully at our next meeting as well. And you all will call it Rachel, in great noise source on the page. I think those are all of the updates. Did I miss anyone? I want to thank Rep Edwards for his time on the committee, and of course, thankful to have Rep Cole in place of Rep Edwards. And with that, although he just put a bite in his mouth, I'm still going to put Senator Miller on the spot to start our introduction.
I represent the Senate. I'm Senator Josh Miller.
Community advisor, my name is Dennis Taylor, Project Weather Renewed.
Good afternoon, Todd Manny from Smithfield Emergency Management, and I represent Providence County, but not the city, but the League of Cities and Towns.
I'm Justin Burke. I'm a addiction medicine physician as an expert representative.
Katie Show, I'm the town manager in Warren, and I'm representing Bristol County. Good afternoon, we go see that region general.
Afternoon, Joe Pratt, report with North Bob, representing Newport. Hi, everyone, I'm Brandon Smith, I'm an expert advisor and a professor at the School of Public Health at Rhode.
What's that like a vision about? Everyone knows you can.
I'm Lauren Sarah. I am the President and Director of Policy Planning and Research for the Executive Office of Human Services.
Thank you. And we do welcome all of our guests and attendees this afternoon. This slide needs no introduction. You have seen it 1,000 times. I will not dwell. We got work to do. We're going to do some work.
You're running comparative.
Yeah, you're in the minute. With that, all right, man, hand it over to you.
Yes, thank you.
Yeah.
So I am going to start by saying that we have had our meetings run like 5 weeks between them and 3 weeks between them. And the last 3 weeks, there have not been a lot of updates. There are many things at purchasing. And so you can see everything that we have put forth at this link. For those, you can look at the link in the deck to see any information on where we are. There's a little bit that I can say though, I think that's doable for me to say. We are working with BHDDH. They have a contract with Galilee. The Galilee program is 20, working on 14 additional residential beds, and the procurement for our residential beds is not done yet. They're working hard on it, and it's at purchasing, ready to be announced very soon. But there was a little bit of additional money. You're going to see. We're going to talk about the process of dealing with it today. But Galley ran into some problems with construction and timeframe and needed a little bit of additional dollars, and it was the exact thing that you had said that we should spend this on, and so we are going to be able to contribute to that. So new resident who has coming, and that's in process, and we can talk about it because of this existing contract that the HDH has. We've also heard substantial feedback from this committee as well as through the task force and our state partners about the need for addressing. We had the discussion of xylazine issues here and many places within the task force. So we are, having heard that, we are in the process of determining the most effective and quickest path to addressing that, and expect to allocate the remainder of the emergency dollars that you allocated. It just makes sense. It is an emergency. It's a new emergency. I'm seeing nods on the table. We must do something about wound care, and there are maybe a couple ways that we can do that. So that with the rest of the emergency dollars for FY23, that is planned. We need to do it in the appropriate procurement, so I cannot open up a conversation and say, who shall we give it to? That is not the way that procurement comes. But we are doing our due diligence and research and hope to have an announcement for that. All right. Any questions before I go about like where we are with anything we need?
And the idea is increasing access to wound care. Or is that where the procurement's going, is to increase access to healthcare that includes?
Yes, to make sure that we have services for people who have used xylazine and need that. Any other questions? All right, so this this conversation that I just had underscores the need for us to have a good process for when things change. And so, and as we were thinking about the process for when things change, when things are come up or emerging, flowing or flexible, we decided that we would all be well served by putting the entire process on paper. So for those of you online, this will be posted, but these are the I'm going to go over a process that folks have in front of them. These are the components of the workflow that we're going to be discussing. So in this, and we have about 20 minutes, 20 minutes. So I'm going to go through, I know you haven't seen it yet. I'm going to go through it. You can ask questions. You can see that there is a big draft watermark all over this. We at the state feel comfortable with it. We're not asking for a vote because we're really just sharing our state process. But as always, if you have thoughts or input and want to give us some ideas about how you think it might work better, or community input into the state process, we're obviously happy to take that. And then we will confirm this and post it and send it out. So we start with the initial allocation process. This is just the state that remind you how it works. We start planning for, and I'm going to use the example of the FY25 budget. We start planning for the FY25 budget this coming July, months. State agencies prepare proposals, and we get them through our processes and the Office of Management and Budget and the governor's budget. We need to submit formally by October month what we think should be. And so the secretary is going to be looking at it long before October. So as soon as the budget passes in June, we flip and start planning, not for the budget year we're in, but for the next budget. The governor presents his budget proposals to the General Assembly by the end of January in 2024. The General Assembly holds hearings. That's what we're doing now for this coming year's budget. But they'll hold hearings throughout the winter and the spring of 2024 and 2025. They negotiate, it passes, we signed by the governor in June, and then we start our hearing process for that. So just a reminder. And here is how we are proposing to formalize the decision process for your work that lines up. You all went through this last year, but it was very rushed. And we were sort of doing 2 years at once because we had to catch up with these. So we are proposing, that in June, the governor's overdose task force is going to make their formal recommendations on priorities that are aligned with their strategic plan. And that includes working group meetings and input and the plenary community conversation that happens in May. So last week, the task force had that plenary community conversation. There are 150 people there, split into groups. Folks, I think, enjoyed the discussion. There were rich discussions. It's all flowing up. Task Force Director Kathy Schultz is responsible for pulling it all together and saying, here is what the task force has told you, OSAC, that is important. So we will share that with you in June. And then we'll have a discussion. OSAC can consider other community-based processes that could eventually include recommendations from municipal members and municipal towns. We'll be talking to the league to formalize that. And then direct to OSAC recommendations that come through public comment here, online and in the room, and that we can request through a web-based form that we are figuring out how to do. We're going to say, hey, community, what do you think? What about? Then our staff team will have these recommendations and draft a proposal for you to fully take apart, say yes to, say no to, in June and July. So you'll have that most likely June and then definitely July and then August. The conversation will continue. We'll do it by the 4 pillars as we have, plus the social determinants of health, merging issues, communications, and data. That's exactly what we did last time. And I just want to say out loud always that the proposal shall encompass your approved principles, acknowledging structural racism, centering equity, and the need to eliminate disparities, and it must align with the task force strategic plan. So that's how we're just sort of making it all work together. And the proposal needs to include considerations of infrastructure needs and monitoring of funding use and compliance. And we have to have it all together. It needs to be a good package moving forward. And then we propose that the actual recommendation process takes place with these components in July and August. So we'll provide you that initial funding proposal at least a week before the July committee meeting. We'll be able to answer questions. We'll talk about it in July and you'll make your decision in August. So you'll have a good month to kick it around, think about it, ask us questions, suggest other things. Then we present the budget recommendations to the secretary following the August meeting. The secretary will make the final decisions and include those in a formal letter back to you, as Secretary Rhode did last time, Secretary Harris will do this time. And then the secretary will direct us to include the approved items in our budget proposal, the EOHHS budget proposal, and then the other agencies. If it is a Rhode, Department of Health budgets. And then we will, in order to do that, the staff will make an initial determination. Where do we think these dollars will be procured out? Because it's sometimes not always epic. Like we have at EOHHS, the Overdose Prevention Center contract. BHDH has the recovery contracts. Rhode has the outreach contracts. Those are pretty clear. There's others that we'll have to figure. So I'll take a breath there. So just to sum up, public input through the task force, your 2 months at least of discussion. It moves into the budget, it gets put into the budget, and then it goes through the legislative process. That's where we are for FY20. Procurement process post-budget passage. So this year's budget for FY24 is about to pass this coming year's budget. And this is our proposed timeline and process for implementation of procurement of that. I could take questions on what I just did. It would be easier. I could stop for a moment with questions. If there are any on the
Yeah, a couple. In outlining the key points that you did, it may already be we want something here about outcomes And that we really want to make sure we're looking at the outcomes are, what the decisions are. That's point one. Point two, we spent a lot of time when we first got together about these funds not being, we spend dollars. State, should we spell that out to make sure that settlement funds are fully involved?
Any other questions?
Just a quick comment, thank you for doing this. I think this is incredible. This is very transparent. I love the idea of like the web-based forms. We had talked about trying to incorporate other ideas. And I imagine this took a lot of time. This is really great. Thank you.
Team effort.
And
Any other questions before we move on? All right, so now we are talking about the FY 24 budget was passed. Thank you, legislature. And now we have to go into the procurement. So when it passes, the secretary will ask the OSAC manager to develop an approach for spending the dollars. A lot of these dollars we know from this, you approve them, some of them, many of them are sustainability. So this year might not be as difficult as either pre was or subsequent years, but still, we need to know what are we sustaining, how are we doing it, what are the, what are the contract mechanisms? The OSAC manager will work with the interagency management team, and that is listed for the analysis to develop the approach to spending. And we take the context of what we say. So we go back and look at the notes. Joe has just said, we want to do these two things. So we're going to have that in our minds. And then throughout the fall, as we plan for the FY 25 budget process, we are going into procurement. We are, we're making our plan, who's going to procure, who's going to write the things, who's going to, are we doing a new procurement, what do we need to do for requests for proposals and so on. Once the spending plan has been vetted and approved by the management team, we are now proposing an executive committee within our agencies for good governance, just to be sort of making sure that other eyes are. It doesn't take anything away from what you're doing. It's not to decide anything that goes seconds. It is to say, hey, staff, what decisions are you making? Does this make sense? Does this fit within, what OSAC has said? So it's just we realized this year we didn't have that governance, and things are always better with governance. So we're going to institute that, and everybody who has thought about it and said that makes sense. And the final decision-making responsibility for like things that are not clear rides with the secretary. The secretary has that, is responsible for this through the settlement, and so that it will go up to him now, and the secretary will make any final decisions that need to be made on procurement activities. We report all decisions back to you, and the task force director, which is plugged in, reports all decisions back to the task force. And so we keep that alignment because, again, it's how we get the community engagement on the task. So that is the procurement process. It's like what we did plus from extra governance, just keep us organized. Any questions on that?
sorry, I've been very, very talkative today. Will part of this include how the RFP is structured? And then I feel like sometimes this committee said we want to put money towards like youth prevention, and very much it's based on the execution. That can mean anything. So we can waste that money potentially, or it could go extremely well. Is part of this group to come up with the most ideal ways for, is that kind of the idea? Things is great.
Yeah, just to make sure, we don't want to waste a dime.
Yeah.
We don't want to waste a penny. So just having enough eyes on it, making sure that the decisions are being made, it's just really formalizing what we did this year and giving it a little bit of structure.
But can I
Please.
yes, still, and it is your job to talk about it, but as also informed by this committee, so it's not like it has been our practice to give guidance, right? And it's continued to be an expectation.
And sorry, a question of my own ignorance, community chair of OSAC. Beautiful, okay. as far as the membership team, one thing that we've talked about a lot is being very inclusive of people with lived experience on the committee. And I wonder if it might make sense to try to include that in the execution governance structure as well.
I mean, the community co-chair of the task force in the governance structure, and that person is required to have lived experience. And then also the staff have lived experience, with the director of the task force and the director of OSAT, or the manager of OSAT have lived experience, but they're not necessarily being structurally other than that, but there is reasonable hours.
I qualify that. But I have limited community experience. I mean, I think as I'm.
I was thinking about Tommy, so there's you and Tommy.
But you were asking about this.
I just in general in the governance structure, especially if that's going to be the execution. I actually think that's where people on the ground can offer the most insight.
I misunderstood the question.
Got it.
All right, any other? So the last part of this process is the reallocation of the emergency allocation. I think is really important for us to get right. So there throughout the procurement, and I've been doing it now for a number of years, other people in the room have been doing it for longer. There are always times when the procured project budgets come in under, comes over, but often under what was allotted. So we have $1 million to spend, the Congress will come in and they will add up to $900. And so what do we do with that $100? So this is not, what I'm talking about is not underspending. We're not saying that a vendor has $1 million contract and they're not spending that. That's a different problem. That's not contract management. We're gonna make sure they bill, we're gonna make sure they spend. If they don't spend, they can't spend, that we might have to take that money back. Like, they're not gonna spend it, we'll take it back, they can't have it for free. But that's a difference, that's a contract. This is when we procure and the numbers don't add up to what we have. Since state agency staff are the only ones that are allowed this direct input into procurement processing by law, something you can do about that, the management team is the team that will handle those requests. And so we are balancing the requirement that state agency staff do the direct procurement with our commitment to transparency to you. And so that's why we want to put this process on the table, have you talk about it, have you tell us what you think, and then we'll follow it. So there's a small amount of underspend, there's a big amount. So we've with help from our chair and some other state colleagues, we've come up with 15% of a pillar. I'm going to just give an example for round numbers because it's easier. I'm saying for the treatment pillar, there's $2 million. So 15% of that is $300,000. So if something comes, if the procurement of that $2 million thing gets to 1.8 and we have $200,000 left, we are saying that the management team will want to reallocate within the pillar. We know that there's another thing that isn't funded enough, we can put it there. But within the pillar, as you've told us to do, what you've told us to do with that pillar, not like whatever we want, with your direction to the pillar. If for some reason there isn't any, then we will review the other needs and the other pillars and reallocate and come back to you the very next time to say, here is what we are doing because there wasn't anything in this pillar. There's always something. I'm not really worried about it, but we wanted to just have a plan.
Can I ask you about that?
Susan.
So using the example that you're using, if there's 200,000 left after $1 million in contract.
$2 million.
Right, and it's within your 15% or whatever the example would be. So does that 200,000 have to trigger another procurement? Or is it something?
It would depend. Like, maybe there's something that is going really well everybody knows it's going well,
Yeah.
and we wanna do more.
Yeah,
It's just adding to a contract we don't have to do.
so it could be added to a contract, like using the example again of like recovery housing. And it was for 15 beds. You could say, here's another 200,000, add another bed. Without procurement,
Without, and we have to go to purchasing and add the money, but it's not a whole.
yeah,
So,
I just don't want it to happen 9 months later.
exactly. Underspends of more money, so 15% at minimum. Here, we would, again, look to allocate it in the same pillar because it would just be what you told us to do anyway. If it's small, I mean, even if it's over 50%, if we can allocate within the pillar, because we would have put it there anyway, that would be what we propose to do. But if we can't, for these big larger ones, if we can't allocate it within the pillar, we are proposing that we bring it back to you. We bring it to, we looked at other pillars and bring the proposal back to you for review and input, because you made your decisions on the percentages of the pillars with care. And if we cannot fund something within that pillar, we think you need to see it and grapple with it and tell us what to do at the next possible meeting. And then when it's approved, when you tell us what to do, we'll just follow the steps. So thoughts, perspectives, agreement or concern?
I think it makes sense, particularly staying within the building. The one question I would have is, does the committee, this committee have responsibility to have more? I don't want to take into consideration things like all company, other than to be here. So could there be a step in there? The management movement back and says, here's what we think makes sense. Then this committee could weigh in and say, what about you just sort of a needle here, is that fit? Just wondering process wise, is there, are we not fulfilling our needs in some way? Just.
I think you're saying the same thing, because under 15% or less, management team would have the authority to reallocate within the pillar. If by stretch of the imagination, they cannot reallocate within the pillar, they can reallocate outside the pillar, but we don't anticipate that is going to happen. Above 15%, they would also still be expected to reallocate within the pillar. If they could not reallocate within the pillar, the difference between the under 15 and under and above 15 is that they would come back to the committee first before reallocating to them. They come back with a proposal, as opposed to coming back to inform on it.
I'm just wondering. Well. Staff makes, and I know the secretary was all the city, but before it's finalized, just in case there's input that comes from some of these public sessions, that we can make sure that we're bringing attention. Just a question.
No, it's a good question. I'll share my one concern with that for this meeting is my one concern. And so I feel comfortable, but obviously I feel comfortable that within the 15%, because we will have already had discussion about what our priorities are and the pillars and our principles and, you know, already allocated it, that they will continue to apply that guidance in the reallocation of it. My concern with expediency there is if we have to bring everything back, it just will be in the next fiscal year. Like we get again trying to allocate dollars. I'm personally more concerned with the pillars.
Yeah, that makes sense. I don't think maybe this one is meaningful. That's a good direction is to have a mission to involve. But I don't think we're in the business and deciding which one we're going to I don't think that I will have to know about. And I think we need a certain time. And so I agree that as pillar thing, yes, you have to come back. Because then you are but within the pillar. As long as there's transparency about who's getting more money, and I think that's why I think the transparency for procurement, like this is where money has been going, as updated, I think is the most.
The thought, Joe, that I would have is that, you know, within the pillar, it starts to get you into the contract thing, because it's like, it's kind of that, because we know the what, the goals that we're trying to reach, the next question is the who, and you don't want to be in, you can't really be in the who, but it's when we change the what between recovery and treatment or social determinants and harm reduction.
Other thoughts? It's just kind of roll into the next chapter. But yeah, I agree with those points, Marty and Carrie. I have a separate question maybe from this, which is about the overall underspend. So this fiscal year closes July 1st. When will we know or have a good sense of surplus essentially that might carry over because of delays or underspending on existing contracts? Like, I just want to get a sense of what the delay is and the reporting on that.
So because we started in, to even start, all of our contracts span, fiscal years. That's perhaps, you know, even all the contracts they span fiscal years. I will also tell you from a contracting and procurement perspective, it's kind of better that that happens because having a contract be up on June 30th, because it's the time of fiscal close, it can be very painful because we need to re-up it. It's just hard to do right when the state is doing all of the fiscal close. So having contracts that are up in August, September, October, November, just from a bureaucratic perspective. So they'll always go over it. And what we have said is, you know, we are thinking that we are more interested in having people spend down than get clawed back. So they can spend into the year. We will, you know, so I will tell you that at June 30th, there isn't any overage. And for the things, a couple of things that we haven't done yet, so we told you last time transparently that we have not procured some of the housing work, and although we're moving on that, I'm happy to say, and the trauma response and one of the family support. We still think that that's what we're doing. We are not going to just say, you know, that we shouldn't do that. We should just do that as soon as we can for a year project to start in early April. But we will, but as contracts do come up, there will be a question of do we do a no cost extension to give, like, if they're close and they need to spend out a little bit. We will share that with you. I think we'll make our best to try to see if it makes sense for us to make a determination like they're closed for, they underspent, they're not doing what they said they were going to do. The contract is over. We don't really think, you know, we don't think, you know, our contract management that they should be. I don't think idea that that's going to happen, but I think it makes sense to have the ability to say, no, don't spend on that. We'll take it and we'll bring it back to you, and then you can help us reality that. So I know I have very few minutes left. Let me just talk to the emergency allocation. So these have been, these were $500,000 that you did for 23, and you did again for 24 to deal with new urgent things. You know, we spent some of the warming center, we're proposing for wound care. We propose that these allocations be made using the government's approach that we talked about, with all available emerging information, things that happen here, things that happen at the task force, and past recommendations, and that the secretary or their designee will notify us within 30 days. So you will be telling us, you will have a conversation, and somebody will say, this might be a good use of it. Then we take that into account and we try and, you know, the most important thing is to spend those. reactions.
Any final questions?
Yes, well, it fits, it's like a strategy, really it's a tactic. You know, through the procurement, and in this case, yeah, 16 grants through the development.
One thing on the emergency.
Yeah.
So in the previous, in the year's recommendations that covers the emergency allocations that we used this year, that there was $500,000, just as a reminder.
Yes.
And was there any problem, or is there a balance on that that would be carried over? So is it determined that next year's is going to be $500,000, or is it $500,000 plus what we didn't use this year, or?
There's $155,000 left in it now, which was aiming to go to wound care. If we don't spend all of it, yes, I would be my understanding that it would go forward in that emergency line.
And is it, are we just all thinking that we're gonna maintain $500,000 as what we use as emergency, and that'll be 1.6 point something?
That will be our decision.
That'll be our
That's your
decision.
decision.
And one other question on that, was there any difficulty if there's only 1.3 left, or 135,000 left? There was no problem with the process to get emergency money?
I don't remember, I think James may have done the procurement for the warming stations.
Yeah.
It happened.
Okay.
So generally with this, subcommittee members, your general degree of comfort with what is reflected, because you're not voting on it, but we want your feedback. Be the generally comfortable with what's been outlined.
Everything's on.
Yeah.
Yes, I just seen exactly, how I have been doing the whole procedures and reading the procedures, stuff like that. I think personally, it is okay when we see here, the way that you structure that. I think kudos to you and the team, because I think it's spell out exactly what we need for in that particular kind of funds. I guess that you did a good job, and now you have to commend you for that.
Appreciate it. Really was a team effort. Awesome. Nice.
I saw a lot of thumbs up, so I think we're good to continue. Excellent, thank you. Thank you. Did I skip the part one? Oh, no? I'll find my own thing. I might skip the part. We're gonna pause for public comment. Either through the chat or in the room. I'll remind folks, we appreciate when you introduce yourself, we appreciate if you would limit yourself to 2 minutes, but would welcome any public comment. Yeah, exactly.
Hi, I'm Tracy Green. I am from Rhode Island Hospital, but I actually have a comment and question or thought for the group. We're doing a lot of wound care kit preparation and creation in many states and talking to people about xylazine and other wound care needs. And the most expensive component is oftentimes the metahoney or the other, which is oftentimes has to be compounded. And since we sit here on the campus of Rhode Island University, with the potential capacity to do a Rhode Island type focus compounding and we did during COVID, or the hand sanitizer otherwise. Just the thought to maybe thinking about this in that specifically to that could be really for wound care could be unique. Just an idea. We're metahoney. Yeah, but another colleague is. There should be one. Just.
No, I'll let them know. I lost track of, did you email? I can't see the comments. Oh, I didn't know. Oh, thank you. Yes.
Tracy, is there a dollar amount in that?
I have no idea, but I think I'm therapist going there and I haven't sent it over, haven't you, but, yeah.
Our dean was just here. Yes.
Any final comments at this time? There'll be another opportunity at the end of the meeting. Not seeing any, we will continue. Dr. Green, actually, you can keep on. Dr. Green, we welcome you to the OSAC and appreciate you making time to update us. If there was something to go into the podium for us.
Right.
You guys will advance the slides. Right?
Yes.
Well, I'm gonna share this, so you'll hear with, staff, so we don't know. So I'm Tracy Green, I'm from Rhode Island Hospital, in the program on opioids and overdose, and, I'm trying to with Jeff Bradford, who is. So the next slide just reflects some of our disclosures. Which you probably can see in our hand, but we have no comments and disclosures, to share, but we do have funding from NIH, from NIDA for the National Institute on Drug Abuse for the study you're going to hear about today. And then also just by way of epistemologic humility, that from whence I come, I'm a mom, I'm a parent, a wife, partner, so a person living chronic pain and remission. So just in terms of where I come from, I'm a researcher, and this is an area of interest that's really important to me. Cheers.
I'm just a professor here, that's all.
But next slide. So we started a project on pharmacy care and focused that on asking the big question, could pharmacy be a place where medications for opioid use disorder and the related continuum of care could be provided? So we explored induction maintenance therapy because we had already started doing rescue or naloxone provision in the pharmacies in Rhode Island. And that was a trend or an idea that was spread across the country. So it's really exciting for Rhode Island to be a place of innovation for pharmacy naloxone. So our trial compared two arms of usual care in the community, which we have many good choices, and compared that to pharmacy-based care. So it was on clinicaltrials.gov, I think it's still is actually. And the next slide. Really, this began because of a global deep dive that I started out doing in Scotland because I was trying to understand how to do naloxone right in a pharmacy. And they were like, well, of course we do naloxone because we do everything else here for medication for opioid use disorder, HIV. So a full service kind of drug user health hub, if you will, in that the pharmacy was very much part of a public health solution. So syringe exchange was possible there, housing support, connections to like multiple levels of care. So naloxone and Suboxone and methadone were part of that. So we see though, when looking across the US, we talked to people in Scotland, in Australia, and in Canada, we saw that most of the provision of pharmacy-based care was methadone, that was integrated with other harm reduction services, that it was set within a community rather than an institution, kind of medical environment. And it was part of an established billing structure. So it was already something that pharmacists identified as a provider and part of the care team they could bill for their services. And stigma reduction was a continuing, despite the number of decades of these services being available, stigma reduction was a constant and a really important component. And then some changed their physical sites for the pharmacy to be able to have more private or semi-private space. So these were things like as we were doing our homework and thinking about the study. The next slide, and let us start on this. Let Chuck to welcome this.
All right, thanks, everybody. Thanks for coming down to Rhode here. Lots of activity going on. So one of the things that we've been successful actually at URI and across the nation in extending care and starting care, right? What are we trying to do? Increase and sustain access to care through this legal agreement. Rhode Island was one of the first states to have this collaborative practice agreement. And this is from the Centers for Disease Control and Prevention. Really all this is something that we do in all of our activities is we collaborate and work with folks to get more stuff done. So this is saying pharmacists are in those community settings. They're accessible. They're within 5 miles of 90% of the population. So it just makes sense that of the 60,000 pharmacies in the nation, we should figure out how we can use that to provide care. We started doing vaccinations over 25, 30 years ago. Rhode Island pharmacists gave the majority of COVID vaccinations in this state and across the nation. So what we're doing here is we took some of the examples of
And more than 10 years ago, we did a CPA for naloxone. We were the first statewide agreement for that. And beyond that, Dr. Jacobson led a study doing Lyme disease prophylaxis through a CPA here in South County. Maybe some of you have heard of Lyme disease. It exists here in a very big way. So what CPAs really do are really sort of three main ingredients, which is saying, hey, doctor, right now our law only allows MDs. So here's an MD. We want a formal relationship. How do we take care of your patients better? Delegate patient care functions. Is it to manage heart failure? Is it to manage addiction? Is it to prophylax against Lyme disease? Is it to provide naloxone? And then contain negotiated conditions. Again, what are those conditions? What are those activities? Are you doing a physical exam? Are you setting training requirements? And so all of this is written into our regulations and our laws. And we said this is a way to really extend addiction care. Next slide, please. So what we did is initially started with a maintenance CPA, and this was the first one in the country. It was a group coming on 5 years ago, and had this a while here. And so what it does is a participating trained pharmacist, so I'll talk about training next, to maintain patients on the MOUD that we can get in pharmacies in the US. We can't have methadone. Methadone is not allowed to be dispensed in pharmacies in the US yet, but there is a federal law that will allow that if it goes through Congress. So we use buprenorphine, which is Subutex, buprenorphine naloxone. I think for the purposes of this conversation, we'll just call buprenorphine to include sort of all those factors. We also had naltrexone. There's an oral form, which is really a lead into the intramuscular form. Sort of a side note, what's interesting when you do research is you've run into some barriers that pharmacists weren't allowed to give long-acting medications, although they can give vaccines, which led to a law that was passed and regulations now allow pharmacists to administer medications. So if you were getting medications by really any route other than intravenously, your pharmacist can give it to you if it's prescribed or via one of these protocols. And so this is between, we partner with Genoa Healthcare, their community pharmacies, data waiver prescribers around the state, and also providers from the opioid treatment programs. Next slide. Please.
Yeah.
Oh, maybe the benefit, yeah.
Sorry. Again, yeah.
Clicked a bunch of times.
We'll just keep.
No,
keep
keep
clicking.
going.
Okay.
We'll get there. Any questions?
Maybe I should exit the presentation.
Or,
There we go. So, do we teach addiction in pharmacy school? Yes. Prior to the waiver, the data waiver required for buprenorphine prescribing went away in December, because we started this in 2018, is we duplicated the education that MDs get and gave it to pharmacists with a lot of other added components. So pharmacists learn motivational interviewing, which is really harm reduction in communication. It's about meeting people where they're at, understanding what their understanding is and meeting them there. We trained our pharmacists in clinical documentation. We used both urine. We did not use urine testing, but we talked about it. We used oral swab testing, so a sort of a more humane way of doing toxicology testing. We talked about harm reduction focused on people who were leaving incarceration to be in the study. And then again, as Dr. Green said, talk about stigma reduction. So we trained 10 pharmacists in May for a pilot, talk about in the following November. We trained 8 more pharmacists, and then as pharmacists came into employment with Genoa, we trained them as well, using again ASAM or the American Society for Addiction Medicine 8-hour training there. We had ongoing support. Again, I was a small state. I can go to all the generalists in a day across the state. We did detailing weekly check-ins and then newsletters talking about sort of how the study went. So really, again, the CPA is a partnership, and research team and the pharmacists were also closely partnered. Next slide, please. So what's interesting is that we are not seeing the increases in buprenorphine meeting the need here. This is data from Prevent Overdose Orion. So we saw it was going up in 2019, also in 2020, and then started to decline. Now, it's not large declines, but you can see sort of the yellow-orange red there is a decline. So clearly there's a need for getting more prescriptions out there, the number of patients actively receiving buprenorphine. Next slide, please. So really what has been in vogue is this idea of low barrier care. So the average, if you don't know this already, the study showed that the average number of days a person needs to wait to get into buprenorphine care is 26 days. 26 days to not die from fentanyl, right? We're all familiar with this. And so we said, this is unacceptable, even to get into primary care offices, again, which are a whole different deal. It takes weeks to get in. We don't have weeks to do this. We need people, to quote Jonathan Boyer, that window of willingness to say, let's get you treatment today, right? Don't wait until next Wednesday between 9 a.m. and 10 a.m. to do this. Let's do it whenever you're ready. Pharmacies are there. So we call this Pharmacy Bridge, the Ode to Rhode Island, taking you as far as you want to go today. Again, it's really individualized care. It's that motivational interviewing idea of patient-centered care to improve patients with OUDs, quality of life and remission. And again, so low barrier of entry, but also longitudinal. Remember, what healthcare entity never closed during the pandemic? It's not rhetorical. There we go, pharmacies. Active learning, this is professor. So if you think of addiction care or chronic medicine or chronic gut medications nailed to you and things like that, right? And OTPs didn't close either. You heard that. So it's important to think about what's determined to be essential care and how the services are delivered in a community-focused way. Next slide. So we said, I really wish I knew the first conversation, the first email that Tracy said, what should we do? Because DEA and SAMHSA about 3 years ago said, now you can't have audio-only prescribing of buprenorphine. Maybe we really need to think about, instead of just randomizing people to usual care or to pharmacy care and our maintenance CPA, how about we start people on therapy? We really are seeing a need to have people start. So one of the things we did actually in 2019 is we were the first state to have withdrawal treatment, where a patient was assessed by the pharmacist. They were given 24 hours of medicine. So this is a protocol at Genova. So people can walk in and just get withdrawal care. We had one patient do it several days and actually get into treatment after that. Again, we depend that on their trained assessment of the degree of withdrawal the patient's in. So buprenorphine induction was sort of an extension of our maintenance CPA, this withdrawal protocol, and say, it's time for pharmacists to just start people on therapy. They were trained as part of this, as part of their education. Our providers and the CPA were in favor of this. And because the provider still needs to be involved, it really was called physician delegated induction. All of this is collaboration, right? We know healthcare is done better when it's interprofessional and collaborative. And then the patient can become treatment. Really, what I call no barrier therapy is sort of walk into the pharmacy and do it. I mean, I got a call, I'm sitting at home, you know, in my home office, and they said, hey, there's 2 patients here at Genoa to do this. I'm like, okay, again, this is 10 a.m. I'm coming down to 1. And we got people medicine that day. Couple people, really, really astounding thing. And we got 100 patients involved, and talk more about that data. Next slide. So what that process is basically, we extended this to several different environments where we have people who need this type of care, right? So presenting to the pharmacy, walk into Genoa, majority of our patients were actually word of mouth or outreach. So that's an important component of this. They had a history of opioid use. And again, it was also, their chart history and their interest in therapy. And so in the pharmacy, there's really 3 ways to do this. We use what's called the COW scale, or clinical opiate withdrawal scale. And if they had no withdrawal, they could start induction. If they had mild to moderate withdrawal, they could either be bridged with therapy, they could have withdrawal treatment, or they could be referred to other services. So again, even if the care is not provided at the pharmacy, they're a touch point to send to care. They're in severe withdrawal. We felt that was probably not a time to start therapy, but because of the withdrawal protocol, we could still make sure they were alive to come back to get treatment when they wanted. So that was that, or we referred to other folks there. Next slide. So Dr. Green will take away the results. Oh, yeah.
So if they're, you probably said this.
That's okay.
If they're secure withdrawal, where is the withdrawal, where are they?
So a patient comes in, the pharmacist evaluates them, says, gosh, your COWS is over 25 in this case. They can be given withdrawal treatment also with buprenorphine and be counseled to come back the next day or to go to some other place to get treatment.
And there's other places like the ER or somewhere else?
Patient directed, wherever the patient wanted to go, wherever they felt the least stigma.
So they could be provided withdrawal supports at that time, like literally in the moment that they were there. But if they were really severe withdrawal, they probably should go to the hospital and be supported with additional care. So that was usually where we didn't have people think
We had to
didn't
not.
have any people in severe withdrawal, but the pharmacists were all trained to be able to provide. So in this way, sort of acute, they really could cover acute care. Withdrawal treatment is something we only used it once, and they came back 7 times, and eventually inducted. At the time, we didn't have the induction protocol in place. It hadn't been approved, but it would have been wonderful. We could have done withdrawal support, and when the person was ready, we could have started at the pharmacy, and then they could have stayed on, and they could have continued on to maintenance. Like that's sort of the real vision of the full continuum of care.
And if I can add, just add one thing, I think an unexplored and not the topic of this is withdrawal treatment, sort of in all healthcare settings, to say, if you're in withdrawal and you're going to use an opioid, let's give you the safest opioid, which is buprenorphine, and you have to go get a physical buprenorphine right then and be mailed to you, and being evaluated and referred to care, be treated like a human, and all these other things can happen in that physical environment. I think that's what's so important, is that they create an environment of, I want to help you, and here's the thing that's going to help you, I'm going to counsel you on this, and whenever you're ready, pharmacy's here to bridge to whatever you want. Does that make sense?
So what do we find? We started with 100 patients. So the induction part was a really exciting one, especially during COVID. As you saw, the induction numbers was really tanking, if you will. Like it was not the slope we wanted to see at a time when people were really worried about overdoses increasing. And so what we saw was with 100 patients who were started on induction, that 58 were stabilized. So they came back 2 or more times, which is a very high retention rate for induction. And then those people who continued on 1 month later, 89% who were continued on to pharmacy care, were randomized to continue on to pharmacy care, continued to go after 1 month. And those who were randomized to usual care, only 17%. So a dramatic difference in those 2 arms. And though we haven't published this under peer review, the folks, when we brought our maintenance patients together with the induction patients, we saw that at 1 month, 93% who were randomized to pharmacy care continued at 1 month, compared to 40% usual care. And at 3 months, we have 64% continuing on in pharmacy care and 28% in usual care. How does that compare to other states? When Lauren and I were at the NGA, the National Government Association meeting, the California State Medicaid lead presented, and they shared about their ED Bridge program, expanded medication for opioid use disorder and EDs. Statewide, their numbers at 30 days, 14%, and ED Bridge was 44%. Usual care in Rhode Island, as you saw, was 40. So we're looking, usual care looks about like California best practice, like how top and with pharmacy, we're seeing double that plus in the pharmacy care. So really exciting. And next slide is a reminder of who actually came into the pharmacy. But we saw that a much more diverse, economically, racially, and ethnically diverse group of patients were served by this process. Of being able to have care on demand. So on the left-hand side are some of the demographics you probably know, the adult population of Rhode Island and our induction patients. So we had, most people had no reliable access for a vehicle and a substantial number were unhoused. So in this instance, the people who were being served were really for people who may be challenged by transportation otherwise. But we also did a follow-up analysis, which I was literally looking at results on my phone, the statistician was sent, but the next slide. This reflects who were those folks. It turns out patients who have pain and people who have seen the pharmacy either for OTC medication, they've come for over-the-counter medication. They've tried to, they've thought of the pharmacy as a place that might help, or they have had chronic pain or other health, chronic health condition, especially in the chronic pain. The story of our opioid crisis. These are folks who may not be being met by our current OTP-based methods, or where buprenorphine may be appropriate. There's a long story of history, especially in Rhode Island, for this population, and so it's interesting to see that that's really what came through, and the diversity that we've done. The next slide is just sort of the voices of our patients, and it is animated, so you can sort of see what they said. They felt comfortable to bring their babies to the pharmacy for their visits. I never felt embarrassed going there. The hours were perfect for me. It was even better than I thought it would be. It was quick, easy, clean. People were so nice, not out of my way at all. It was very easy to do. It was convenient. It was convenient, better. And including things that the courteousness and friendliness that they felt that the pharmacy really treated them with respect. That was really important to people, that they were treated with dignity and respect. So just our conclusions, where we see the patients who were inducted in the pharmacy really attained that stabilization that was comparable to what we would see, and not better than community-based usual care. That engaged are really diverse, and a group of people who are not met by our current process. Shoving patients into the current process rather than kind of figuring out how the process could be improved for our patients. And the next animation, I think, is just a reminder of that we saw greater access to treatment to more people, and that people being started in the pharmacy really should have the option to be maintained in the pharmacy. So our next slide is just about some last thoughts on the next steps. the key thing, and like every reporter I ever talked to, well, how's this continuing in what state? Where are there's tons of states interested in it? Lots of federal action, lots of professional interest. A key challenge to impediment to the reality is implementation requires payment because pharmacists are not currently being regarded as providers, so they can't fill their time. So, and this goes for our state and many others. Now, a couple states have that Medicaid has said pharmacists can be paid as prescribers, as providers. We recognize them as providers, and then their services can be billed. Otherwise, it is basically on, I have to write more grants. Happy to do it to continue pharmacy-based care, or other forms of services have to pay for pharmacy time. So it's sort of a policy opportunity on the plate of many states and the country for that matter, or the idea of how to make pharmacy ready. I mean, there are obviously some physical space changes, training issues, important feedback loops that you've heard from Jeff, academic detailing supports, some EMR integration that likely is going to happen, some administrative things that are going to change and are required for billing to occur and all this stuff. If the whole system is going to right to like be a bigger table with more prescribers. But the cool thing is that we can totally do this. I mean, like the systems of care are really hungry for opportunities like this. So the opportunities for, you know, especially the way that the state has created injectable, a lot of injectable medications, both where you know, like Sublocade is injectable and have other injectable medications for MOUD, but this is a whole other field of opportunity and kind of patient-centered options.
And one thing that I'm now really interested in talking to a lot of states about this, because I get an email from some pharmacists in a large Houston chain, and they're sort of like, how do we do this in Texas? And they said, so our CEO saw your New England Journal of Medicine and sent us the article and said, we should do this. I'm like, yes, you should, but here are the things that we need to do. One of the things I think all of us agree on is that there are huge behavioral health needs and there are huge SUD needs. And we do have long-acting injectables for both. And guess who can give both of those now in Rhode Island? Pharmacists. So there's a great opportunity to create CPAs to deliver that care in more convenient settings using the skills that pharmacists already have to do that. So I think those are some things that deserve exploration as well. I'm stealing your thunder.
No, and I think you know, the last with actions that sometimes, you know, whether a pandemic happens again, natural disaster happens again, closure of major clinics providing buprenorphine in a state or city happens again, you know, the ability for pharmacies to kind of be either a constant, an own personal crisis needs spot to start medication, or the system needs more help, kind of a disaster management really for things that happen in our society. So there are a lot of really interesting things that could happen in the pharmacy. So we put together some like, what would it take to kind of do something like this, and building a program. I kind of like to think of short, medium, and longer term capacities. And you know, there's no reason why we couldn't envision 500 induction of 500 patients to make that curve not downward trending, but positive trending in the number of patients on buprenorphine. And then people obviously are inducted and then shift the maintenance, but there's time like to do this that is currently not compensated. It's pharmacist time, technician time, kind of pharmacy, if you will, management time. Oral tox is a little more expensive than urines, but oral tox is certainly more patient-centered. Patients really like that. I think 6 times a year is approximately what happens. We've leveraged our physicians who are oftentimes those on the addiction consult service. They are really good at triaging addiction care, and they practice medicine in a very low barrier approach. This already exists. It exists in the state. And then we felt that community health workers are amazing and would be a real add, considering the kind of, as you saw, transportation and housing and kind of connection needs for people to be able to safely have their medication, store it, and then be served to have a path to housing, have a path.
One innovation that is being done in other states very successfully is training pharmacy technicians as community healthcare workers. And so there's actually movements and there's grant funding for that, so that you don't have to put another person there. There's a person who's already trained to do those kinds of things.
And then I think we gave people phones. That wasn't a determinant of whether people were successfully inducted or retained. In the study, it was always easier to contact people, but you know, we have a lot of services, MTM and other services for transportation and contact, but those like kind of robust infrastructures that are important for society to address some of those social determinants of health. And I think the last slide was just sort of, we put together kind of what, startup, like providing technician training, pharmacist training, and some of the communications of things. How much effort it took to tell people like, no, this is a real thing. Like you really can go to the pharmacy and start treatment and that this is an option. And then that outreach was really, really important. Messaging having a really clear connection with our navigators and rural outreach. Our rural outreach and navigators in Parent Support Network and other harm reduction organizations, just knowing that low barrier care is available. Was some of the things that even having a hotline, people call the view hotline and be like, you know, just walk to the pharmacy and go over and have that conversation. Every prescription still needs a pharmacist. So it's sort of a one-stop shop in that regard to each other. So we figured out some of the general startup and then kind of ongoing costs. And then so per year, I will say many of the costs that are here, and they're probably easier to look at in real detail, but community health workers, we do have a Medicaid, a way to charge and cover their costs. So toxicology, we do have some coverage as well. But some of these, like, how do you offset, like getting the pharmacies kind of ready for this would be an important investment. So we figured out kind of an annual cost and then a per patient per annum cost. I think this might not be in there, I'm not sure, but basically what we figured out is that if between there were patients who couldn't pay and our study paid for their medication. The type of lawsuit, buprenorphine is a fantastic, fantastic way to get out some of the more medication that could go into the hands of people who are would really benefit from it. And then of course covering the cost of recognizing a prescribed pharmacist as a prescriber means that it's not a cost to the state, it's part of what we do, provide quality care. So I think that that's the last animated thought, but yeah. Answer your question.
I'm sorry, we're not taking all questions from the public at this time, but hang on to your turn.
What kind of outreach communication have you had with a large pharmacy chains?
Well,
But how?
so the fifth largest pharmacy chain in the country, General Healthcare. is our partner, and that was our partner, and they're very interested. General Healthcare, as you know, you're like, wait a second, I don't see a sign that says Genoa, milk $1.99. Genoa is it's co-located with community mental health, but they're a regular community pharmacy, other than they don't have, Halloween candy, and they don't have a front store, but they have a fully functioning, fully stocked pharmacy for all medications. Interestingly, we didn't actually use providers who were co-located with them, and they have lots of ideas on how to implement this to optimize some of these things. So that's right now our large partner. I can say that we've also talked to insurers who basically don't need to do. See, if I don't say their name, I think that they see that providing care up front and access to medications up front is cost savings. Like we don't need to do a study to say, well, how many hospitalizations did we prevent them? They already know that. They see that. And so I think there's interest in all of the major groups, if that's what you're getting at.
Yeah, and we've talked to a couple other smaller independent pharmacies and chains for the purposes of the study. Actually, ironically, the state Rhode Island Department of Health limited it to one pharmacy chain for our CPA and for the study. So we weren't really allowed to move to others. So that would be an action or an encouragement. Policy suggestion would be to think about providing and inviting any pharmacy chain that would be willing to, or any pharmacy that would be partner in a CPA would be welcome. The model is not like general specific, but it is absolutely medication first and very, very focused on. The nice thing about John was because they provide behavioral health care, like they always talks about sound. It wasn't a question like, are they going to have it or not, which is something we hear a lot in the media.
And we've already had independent I've had independent. So we've had independent pharmacies and meetings with other hospital chains that want to integrate this into their clinics as well. So it's very collaborative.
Other questions?
Just to follow up on he basically asked what I asked about expanding it. So the Genoa is in clinics. So somebody,
You can walk in and get it.
the study the 100 that created the slides were people that use the clinic or knew that the clinic.
No, they can walk
Was
in,
doing
the
this.
one in Woonsocket is like across from Thunder Mist, like down a couple
Okay.
blocks from Thunder Mist.
Okay.
In kind of a mini mall kind of look to it, They're
Right.
actually close to their business models to be proximal to, hero health, providers. Some of them are across the hall, some of them are around the corner, but basically they're very accessible. With the CCBHC, the Sampson based community, behavioral health center model, they're not located necessarily on there as like a water treatment pharmacy.
Okay, but big picture is that would be that you want the public to know that they can walk into any pharmacy, anything that they thought looked like a.
It would be magical if some of the big chains would do this.
Yeah.
I will be glad if that, I'm happy to
We
start
invite them.
conversations, we invite them all the time. Kind of they do the math and they have different decisions or if there are other reasons for it, I'm not sure. But Genoa,
So,
it's been easier to say.
I mean, I think, I don't want to speak for you, but we kind of welcome the challenge to figure out why, how, and when they could be involved.
The other parts of this, I should say, like the withdrawal support, when you
Yeah.
walk in, would be a phenomenal, large scale
Yeah.
thing that they,
Yeah.
that any pharmacy could do.
Yeah.
The other work, like if you're gonna get an injection, like naltrexone in the tush, like you might wanna have room, that like that kind of thing, maybe.
The opportunity also is,
You should totally.
yeah, you could correct me, is that they figured out how to handle injectables to vaccinate. And so they learned how to spatially handle their pharmacy.
Correct.
Incentives help for that kind of.
Yeah, all those vaccines were paid for. It's the parallel.
Thank you so much for this presentation, and I'm particularly excited about the data that you showed about racial access to the supportive treatment to maintenance, which has been a recognized problem in this committee. So thank you. Dr. Swakabon, I know that you are on Zoom. If you can unmute yourself.
Good afternoon, everyone. So I have I'll need somebody to help advance my slides, but it's really a pleasure to come and talk to the committee today. I've at some public comment times, I've shared about some oral health issues that can occur with people with opioid use disorder, but I'll do it a little bit more and include some graphic pictures for everybody. So, next slide, please. So I'm going to talk a little bit about why people with OUD or SUD may experience some dental problems, talk about how those dental problems may impact recovery, talk about some efforts to address through dental problems, talk a little bit about Suboxone's impact on oral health, some challenges we have, and perhaps some opportunities. So next slide. So why do dental problems occur for people who are using opioids and other substances? A key factor is saliva flow. Saliva, I tell people, is nature's magic potion to keep your mouth healthy. And a lot of medications older adults take cut their saliva flow, and they start having root decay. People who have radiation therapy for head and neck cancer have very dry mouths and experience tooth decay. Similarly, some drugs, including opioids, methamphetamines, and many others, can cut saliva flow, and that increases tooth decay. Combining that with more frequent sugar intake, poor oral hygiene, teeth grinding, and infrequent dental visits can increase tooth decay. On top of that, there may be underlying fear of the dentist, also maybe some mental health problems that might reduce likelihood of dental experiences. People may also have had unfavorable experiences at the dentist, or have not had experiences with dental offices that are recovery friendly, and so they may not want to return. They may also have barriers, including insurance, finances, and transportation. Next slide. And so the data seems to bear this out. Again, not just a Rhode Island thing, but large studies have shown through meta-analyses that people with substance use disorder had more decayed teeth, but fewer restorations, indicating reduced access to dental care, greater tooth loss, non-carious tooth loss, which means from destructive periodontal disease compared to controls. So we know it from the data. We know it also know it from clinical reports. Dentists describing patients they've seen in their offices with significant dental disease. Next slide. And so here, as promised, a few graphic pictures. So why does it matter? Why does increased tooth decay matter? Because ultimately tooth decay can turn into toothaches and abscesses, and patients may end up going to the emergency room, or where unfortunately no treatment can be done, or they may become reliant on analgesics or antibiotics. Also important, it may lead to tooth loss. As you see in this illustration, tooth loss can lead to worse chewing function, dental aesthetic problems, and affecting people's quality of life. So here is a picture again that you see clinically on the left, and radiographically, you can see teeth that are broken off at the gum line and multiple missing teeth. Next slide. So efforts to address through dental treatment. There was one report from University of Utah. They have a new dental school in Utah, where they provided significant dental benefits for one group that was going through recovery and not to another group. And what they found was that the group that received the dental benefits had a much higher rate of success in recovery. We also hear personal stories, and I'm sorry that must have moved there. I'm just gonna go to the next slide, please. I'm just gonna say, because personal stories that we hear from individuals who have had significant need for dental treatment, that one individual who had been in the news, that her picture had been on the news because of her experience with substance use disorder. A dentist reached out to her and offered to provide care. She needed significant dental care due to missing teeth. And a dentist reached out and provided dental care pro bono. She reports that this dental care changed her life. After having her teeth fixed and an improved smile, she was able to get a job. She was able to have a relationship, get married, and is now a parent. So for many folks, dental makes a huge difference. This is something, actually, it was great to see Dr. Bratberg, because I think he was the first to share this information with me, that Suboxone, when used as a film, is highly acidic and can lead to demineralization of the teeth. As you see on the upper right along the gum line, the tooth decay process starting, that kind of those brownish areas. Data from the FDA, people reporting to the FDA, reported kind of the median time of 2 years before experiencing significant tooth decay. Next slide, please. So this was a report that came out from the FDA, warning about dental problems with buprenorphine medicines dissolved in the mouth to treat opioid use disorder and pain. However, stating again, the benefits far outweigh these risks. However, oral health care can help. Not every provider of MOUD is aware of these problems and may not be advising patients. So next slide, please. Dental treatment, unfortunately, is very costly. Replacing missing teeth is not, depending. Medicaid program does cover removable prosthetics. It does not cover implant treatment, for example. In the Utah study, their average cost per patient was over $1,200, but that was in a dental school setting and a number of years ago. Significant prosthodontic rehabilitation can be much more costly. Next slide, please. Does dental appearance dental appearance can impact employability. There was again, a big study done out of England that showed there's abundant and diverse array of research to support that poor dental health poor dental appearance can have negative impacts on employment. Next slide. This is the next slide. This is from a study done at Brandeis where they showed pictures of individuals with poor dentition and recreated positive dentition, and they showed how the probability of employment increased in the top picture by 32%, in the bottom picture by 15% if the individual had an improved dental aesthetics. Next slide. Also, we know from social, and there's a study called At First Glance, Social Meanings of Dental Appearance, and they found that dental appearance had a significant effect on the way we create an impression of another person. Next slide, please. So we do have challenges, and I know we could go on and on. I only have 1 minute left, but again, there's a lot of stigma a lot of opportunities for education in multiple venues. Care is siloed and we lack integration. We don't have good data on the scope of this problem. We also have a limited number of dental providers. We have few safety net providers for uninsured patients. Our Medicaid network is limited, and the FQHCs, their capacity, certainly their capacity to do advanced restorative care is limited. We lack a dental school. And like I said, Medicare doesn't fully cover all of these procedures. Next, please. I said it's costly. This is from Fair Health Consumer, showing some of the costs to restore an individual tooth, or in the bottom, if somebody needed an implant, the costs of all the components, and this is per tooth, can be quite costly. Next slide, please. So again, I know I've probably rushed us, but I do think there are a lot of opportunities to look at oral health, better training across disciplines, better training of oral healthcare providers so they can become recovery friendly, developing programs to make connections between patients in treatment and dentistry to reduce barriers to assessment, treatment plan, and preventive care, and developing programs to support access to and reduce barriers to care for reduced or no cost restorative services. So thanks for this opportunity to just raise awareness of the oral health issues. And I'm happy to take any questions.
Sam, thank you for raising awareness of oral health concerns and its, far-reaching impact on patients with experiencing substance use disorder or certification. Any questions from you? Thank you so much.
Thank you.
Jill, I see your hand, but we're gonna have to hold for public comment.
Okay, I'll just write it in the chat to Dr. Z. Thanks.
Dr. Bradford, along with Dr. Davidson, to share with us about the Community First Responder Program here. All right. Thank you so much for being with us.
Thank you for coming down. So we are going to talk about the Community First Responder Program. We can go to the next slide. I'm going to be quite quick to keep us on schedule. So we are actually located here on the URI campus. So following this meeting, we do invite you all who are here in person with us to walk across the street and to see our facility. So I'd like to introduce our team on the next slide. So I'm Anita Jacobson. I'm a pharmacist. So we are licensed as a wholesale pharmacy over in Laurel Hall, as I said, across the street. We have our program manager, Maciel Alman-Frias, who unfortunately she's on a wonderful Bermuda vacation. So, I'm sure we miss her, but of course she's not missing us. We also have Cindy Wan, who I'd like to have raise your hand, introduce yourself. So she is a certified pharmacy technician who does all of the labeling, delivery, distribution aspects. So she is really the lifeblood of our program, and we are grateful to have her on board. And then my colleague, Jeffrey Bradford, who you've all met, who is our research coordinator. Next slide. So we were first established in 2019 under a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. So we have been doing services throughout Rhode Island for 3 years now. And we have sort of three main goals of our program: to provide education, We do this through continuing education for healthcare professionals, as well as community-based seminars. We also do distribute resources, so predominantly naloxone, but also fentanyl test strips and safer smoking kits as well in the community. And we do offer trainings on demand. People can request a seminar from our website. We have traveled to many different locations throughout giving these free seminars, bringing naloxone with us and helping people get training. Next slide, please. So these are our current activities. So we moved from our SAMHSA funding over to the Department of Health. So we have been collaborating with the Rhode Island Department of Health and the Executive Office of Health and Human Services to provide naloxone distribution predominantly to our community partners. So places like Project Weber Renew, Parent Support Network, AIDS Care Ocean State, so many different community partners. So we are now distributing the TEVA kits. So as of February, 25,000 TEVA naloxone kits came here to the campus. That was quite a day, getting that all included, and Tammy has the muscles to show for it. But we have been getting them out pretty quickly. We'll show you some of the data on our distribution. So people can either come here to Kingston to pick up the kits, our community partners, or we do offer delivery as well. We are quite quick with that. We usually can do a delivery within 24 to 48 hours. As I mentioned, we do the educational seminars on request. We are accredited for continuing education for nurses, pharmacists, licensed mental health counselors, and social workers. So anyone who has an organization or group, they can request that seminar and get free CE for their license. We do also do pop-up events. We have an arrangement with CVS. They allow us to come to their parking lots and set up our table and do naloxone distribution right in their parking lot. And I will tell you, we just distribute a lot more naloxone in the parking lot than they're able to in the pharmacy. And a lot of that just has to do with people not necessarily identifying that they're risk adjacent. So I have, offered to people, hey, would you like a naloxone kit? It's free. It's like a fire extinguisher. You have it. You never have to use it, but it's a good thing to have. And people will say, no, I don't need that. They'll go in, they'll shop, they'll come back out and they'll say, actually my son who lives with me overdosed last week, maybe I should have a kit. I'm thinking, wow, if they turned me down the first time, but also would they have gone into the pharmacy to request this? So there's really, a lack sometimes of awareness that, this is accessible, that it's available, that it's free. The public may not know that. So we try to respond to the rural alerts and go to CVS locations that are in the areas where there is heightened overdose activity. We also do have our naloxone distribution by mail, and this has really gone up in recent months. We have had a big uptick in requests through the mail. We have our modules located on 2 different websites. So one is at URI, so it's uri.edu/CFRP. It's the Community First Responder website, but also Prevent Overdose Rhode Island. People can go to Get Naloxone. They can take a short training and then request the kit to be mailed to their home for free. So we do get different traffic at these 2 websites. We have had more kits distributed from URI, but the Prevent Overdose Rhode Island website has recently very much increased because of messaging, text messaging with the rural alerts that has gone out. So next slide, please. So we invite more organizations to become community partners. We want to get these TEVA kits to the places that are interacting with the public and who have an opportunity to distribute them. So any community-based nonprofit or municipality or harm reduction program, or even some other organizations as well, if you think that you might be an organization who would want to offer this, please fill out the request form and we can talk about setting you up as a community partner. And certainly we want to do this with an equity lens. So we really do prioritize distribution of kits to places who are working with minoritized and marginalized populations. Next slide, please. This is just a screenshot from our website at uri.edu, so people can request a seminar, they can schedule a CE program for healthcare professionals, or they can just take the course, the quick online module, and request naloxone through the mail. It's very low barrier. It comes in plain packaging. It arrives at the home wherever the person requests that it is delivered. Next slide, please. So this is a screenshot of the Prevent Overdose Rhode Island website. So again, at Get Naloxone, similar thing, people can request the free naloxone and other harm reduction supplies to be mailed to them. Next slide, please. So some distribution data. So this is since March of 2020. So we have a little bit over 3 years of data. So for our URI Community First Responder Program, we have distributed 13,496 naloxone kits directly to the public. Of these, 3,448 were from the Prevent Overdose Rhode Island Get Naloxone website. So that has really gone up because that is a relatively new offering. We have distributed over 23,000 fentanyl test strips across Rhode Island. And then our distribution to the community-based nonprofit partners. So in 2022, we distributed 34,872 kits. And so far in 2023, and this includes the TEBA kits, we have distributed 17,583 naloxone kits to community partners. So this is, definitely we're busy over there in Morrell Hall. We have a small space and a small staff, but we do what we can to really provide top quality customer service and to get things to people quickly where they're needed. Next slide, please. So this is from the Department of Health, just showing the naloxone kits distributed in the state from January of 2018 to December of 2022. You can see it has gone up significantly over the years, with 2022 being the highest on record, with 36,590 kits distributed from community partners to the public. Next slide, please. And the greatest number of kits actually was distributed in Q3. So this is when the International Overdose Awareness Day occurs. So that is August 31st. And Project Rubber Renew really takes the lead on International Overdose Awareness Day. We try to support them however we can with getting naloxone kits wherever they need them to be. But you can see that that is the largest order for distribution. And I think that day in particular makes a big component of these kit numbers. Next slide, please. So we do collect data from people who visit our website and take the online modules. We also collect data from people who do the live seminars. So we have had close to 3,000 people attend a live seminar that we do, where we do naloxone training, teaching people how to effectively recognize and respond to an overdose, with a lot of specific information on how they can administer naloxone effectively and appropriately. So we have collected seminar surveys from 993 of those individuals. So that's close to a 34% response rate, which is pretty high as far as survey data goes. And then we have had 3,847 people complete these satisfaction surveys following our online modules. Next slide, please. So that data has been really overwhelmingly positive. So responses from our online modules, we have had 98% of people say they were very satisfied or satisfied with the quality of the online module. From our live seminars, we asked people how confident were they that they would know when naloxone should be initiated. 99% have reported completely or somewhat confident that they would know when naloxone should be initiated. Next slide, please. These are just some names. I won't take the time to read these, but these are different organizations that just this year, so just 2023, have hosted us to come and do overdose response trainings. So it's a lot of different types of organizations. Schools have been a big one, but certainly healthcare organizations, the U.S. Marshal's Office. So it's a lot of different folks have requested a seminar. We can do them in person, or they can be live as a webinar. Next slide, please. I believe it's Dr. Brett Hertz.
Okay, thanks, Dr. Davidson. So the future is buprenorphine, we said before. So over 10 years, we're going to be getting 6,700 30-count bottles of buprenorphine, 6,000 8-milligram tablet 30-count bottles, 700 2-milligram 30-count bottles. So if that was to treat people over the year at an average dose of 16 milligrams per day, that would treat 558 people continuously. Now, we are determining where this can go. The focus is, of course, for uninsured folks. It's very important. We all know that there are Medicaid re-enrollment criteria being implemented in Rhode Island and across the nation. And so there might be an increased number of folks who would want this. We know that when people have treatment, they overdose less. The least frequently identified opioid in toxicology specimens of fatal overdoses is buprenorphine. So it is a life-saving drug. It does not reverse overdoses, but if you're on it, far less likely to have negative effects. And so one of the things that we're waiting on, Dr. Jackson mentioned that we have a wholesaler distributor pharmacy. We are adding a component, and you'll see where this will go in the tour. Controlled substance distributor pharmacy has many, many more requirements than a non-controlled substance pharmacy. We involve the DEA, building a cage and things like that. And what I've been doing the last few months is really actively working with Lynn Mahoney and others to say, where is the best place to put this buprenorphine? How do we get it there? And as I alluded to in the previous presentation, things like withdrawal treatment. I've talked to many independent pharmacies. I've talked to general pharmacies. They're willing to have this sort of free buprenorphine there to then interact with us, with providers to say, go get your free, you've just been released from incarceration. Your Medicaid hasn't come back. Maybe that's a population that could go to a pharmacy and continue or start their buprenorphine there because they know it's there and it's no cost to the settlement. Other things, again, in conjunction with the buprenorphine hotline, even provider offices, if given the safe and dispensing system, provider offices, and there's been several who've been interested in this, could be provided these tools to dispense it. Again, there's lots and lots of regulations and documentation, but people have overcome this. And so I think that that's an exciting thing, considering we have 10 years to go. Setting these things up now is important so that, someone is in withdrawal, not at the general community pharmacy with the CPA, but they're just in a provider office. They can actually give them buprenorphine and administer right there without cost and be managed by our program. Next slide.
So just any questions, we would welcome from the community if there's time.
Thank you. So I have a question. First of all, thank you so much. This was really great. James and I really have to compliment you and your team on everything they're doing and what you've done. For Marty, Warren, James, and I, we're ranking on a weekly, monthly basis on how is the Narcan, Naloxone distribution going, how's the Suboxone distribution going, what's going on. So this is really, really good to see something that we at the Attorney General's office have spent a long time negotiating and working on the product actually go from paper, legal settlement negotiations to practice. And so that's really great. A couple of maybe just ideas to throw at you. One is to maybe speak to the courts, and I would Julie Hamill is a member of the courts, do have a representative in this committee. I don't believe he's here today, but the courts might be like a nice place to also do have a they get a lot of handle, justice assistance, other organizations that work with assisted populations could be useful partners, as well as locations that can be present. Obviously, including a lot of issues and providers in the state. So there's no opportunities and real parties out there. To the extent you guys can be truthful to communicate with courts and help along those lines, perhaps even more. That introduction. I was thinking maybe when guys are all very busy, maybe it would be helpful to have this presentation or similar presentation for the municipalities in town, so that municipalities know where they can go. And I think a lot of first responders already have their supplies, naloxone or other sources, but perhaps, perhaps they don't. Or anyways, I can really use it. And I think it was 67,000. 30 per box. It's about some 6,700 a year, but
6,730
a year. So it's
a year, yes, 10 years worth, sorry. I did not use the word annual because.
Yes. So yeah, thanks. This is really great.
Thank you. Yeah, those are great suggestions.
And I would just say, I'm on the board for the League of Cities and Towns. I think this would be a great thing to present to that board, especially the training opportunities. I know that there's a big appetite, amongst municipal folks to get trained. I know, like, I'm from the town of Warren, we train all of our employees. There were a lot of there's a lot of misunderstanding around naloxone that was very quickly overcome by professionals giving the training. So I think that would, these are the DPW folks, the people who are out in parks, it's really, I think you can get a lot of saturation in that.
Yeah, and we are constantly updating our training. So in fact, if people have had a training a year ago, if they took the new one, it's very different because of the impact of xylazine and what we're seeing in overdose response, increased sedation. There's just a lot of new information. So yeah, we are always happy to do these seminars on request.
I do think this Chiefs Association. What they should have as well to see if they can get a closer track.
That would be wonderful, right? We have done the US District Court and the US Marshals. So that was very recently, within the last months. That has been our only sort of adjacent.
I can help you guys.
Wonderful.
Thank you so much.
Thank you.
Kathy. Update from the task force.
I'm Kathy Schultz, I'm the director of the Government Overdose Task Force. Totally under here, but that's okay. I'm just gonna give a quick update of, we actually, our last task force was a lot of planning. Our work with co-chairs, all volunteers to facilitate and also take notes for breakout sessions. It's important, this was actually for you all here at the Opioid Subcommittee, and it was to have some discussions on recommendations for 2025. So they're in the process of finalizing and looking at the summary. How this process began was they all went into the work groups. They started to have the discussions. Many had surveys with their work group members, and then we brought it to the larger task force, kind of had an additional conversation so that we could really engage the community. Because I think I couldn't say that, Marty, is the task force has an attendance of over 150 people, sometimes close to 200. So we really have that opportunity to get the buy-in and the input from several different layers of stakeholders, including people with lived experience, people boots on the ground, and it's just really important to get that kind of information. And then, really looking at our strategic plan and making sure that we're aligning the recommendations that are coming to you all. So we anticipate that the recommendations should be to you by the first week of June. And that's all I have. Thank you.
As was alluded to earlier in the meeting, we're looking forward to the June, July, and August meetings when we will receive recommendations from the Governor's Overdose Task Force. We'll consider our recommendations for FY25 and in light of not only the priorities and guiding principles that we previously agreed to, but also in light of our experience and our knowledge before 2023. And I also want to let you know that we have been having in between our committee meetings, these meetings, deeper conversation with our state colleagues and partners and that on equity and racial equity and both in alignment with the Governor's Overdose Task Force and the work in the racial equity work group. Consistent with EOHHS priorities and to reflect the input that we received in our meetings of this committee. So, working with the racial equity work group, and I'm so glad you could join in person today. And Governor's Over's Task Force members, we look forward to bringing some, guidance back for your consideration, in June and July.
I add one more thing too. I would like to say thank you to all the members of the OSAC committee that came to the governor's task force meeting. I do apologize, and also their expert advisors, for your participation as well. So thank you very much.
Okay. We will be back in Cranston for the June, July, and August meetings as currently scheduled. If you anticipate being on vacation and you haven't already declined the meeting or communicated, we'll just ask all committee members to keep Lauren apprised, because we do have to have a quorum, and not just to vote, but actually to conduct the meeting, which is why we had a delay start today. And unfortunately, designees are not counted for quorum, so we need committee members present, or to know in advance of the moment for everyone, so that we can reschedule and make accommodations. So, take vacation, just not on a meeting day, or if you do, no one can. And I know we're over, but I do want to, for there are public comments, to receive them at this time. So I know that you had your hand up earlier, so you're trying to tell us who you are.
My name is Sean Moore. I am, a member of the community with lived experience, mostly representing the greater healthcare solutions. Some of the stuff I wanted to ask was covered, I guess, to do with communication, and then I guess what I'd like to do is commend both of you, both the first responders as well as the pharmacy in terms of providing what I would consider equal access, right? Kind of deteriorating some of those barriers that actually comes to including and meeting individuals where they're at, right? Creating this environment of equity. And what I was wondering was in long-term vision of the pharmacy program, are there intentions to create partnerships and collaboration with OCP, the private, private entities where, you know, the continuum of care in terms of that co-occurring necessity, right? If you have individuals who are suffering, you know, mental health complications, right? If we can address the substance complications right there on the spot, how, like, what's the vision behind how you intend on, you know, treating more of the what I think is the underlying complications of mental and behavioral complications. What the vision is behind that? I didn't even pose the question in that way, and if there is a vision behind that, but mainly to commend you for the work that you do, both as first responders and also with that initiative, because I think, you know, looking at the numbers, providing the equal access to diverse populations that don't, you know, talk about is that there's a hospital that we, you know, in the city and the owner there's this pharmacy, it seems as if, you know, these the stigmatization, right, of institutions in general, right, cause like a barriers to those populations, or bring it to the really is as a community health worker myself, I think it really does support the initiative of addressing the cause. And everything, and it's dealing ourselves.
I'm going to invite, for the sake of time, because you could ask a question, I'm going to invite a response to the question offline, if that's okay. Really, certainly. So thank you. And I'm going to remind, I'm looking in the chat, there's no public comments in the chat. Did I miss anyone in the room?
Just wanted to answer.
Here, is a no-brainer and to be never commonly, and it looks like the BIPOC community access better. But I couldn't help but notice a comment with a patient that went to get the services there, saying that they went there because it's not a large entity like a CVS or something. So I was wondering if you did any kind of like data collection around the patients that you interacted with to see if you were to like integrate it with a larger chain, would it work, or would it address some of the stigma issues that you talked about, some of the access thing? So I was just curious if in depth, like around those issues.
And again, I can be that correct, but I'm going to invite you to respond, or Tracy to respond to me. Anyone. Remind folks, if you have the time, to please go across the way, for our, site visit slash show and tell session in person. Here you are. And other than that, I thank everyone for your time and extra time, and, great to see you and drive safely.
Any, presentation for upstairs.
Great.
Yeah.
Thank you very much.
Yeah.